median nerve lesions. We'll be looking at 3 patients one after the other while we are discussing the level of lesions. Let us look at one table to have some details of those patients in terms of etiology, and then we can move on to the clinical features. In this table, as we discuss the median nerve injuries, we have got one patient with the supracondylar fracture above the elbow joint, and then there is a case of wrist/injury, and a third patient is having carpal tunnel syndrome, which will be at the level of flexor retinaculum. So we are discussing the median nerve lesions at a higher level, then at a lower level, and still more distal level. What we find in this table is given the hand of benediction, and we will be discussing the details of this. In the next diagram, we can discuss some of the clinical features that will be evident there. You must have observed when we are in the church, the priest will be giving his blessings, and he has got a typical gesture of his hand. Derived from there only, this hand of benediction term has come in the literature. Here you have to ask the patient to make a fist, and when the patient is making a fist, what you find is the patient is able to fold these 2 medial fingers properly, but the 3 lateral fingers, they are finding difficulty in flexion. And if the patient tries, there will be slight flexion but not the complete movement, and then it appears like the hand of benediction. In these 3 fingers, specifically the index finger will find difficulty in flexion. There is one test also for that, which is called as the pointing index finger. But what exactly is the problem here? This happens in median nerve injuries at a higher level, say for example supracondylar fracture, leading to weakness of some of the muscles, especially the muscles supplied by a deep branch of the median nerve, anterior interosseous nerve in the anterior forearm. We understand that there is a muscle, flexor digitorum profundus, for folding the 4 digits here. And these 2 fingers can be folded by the medial half of flexor digitorum profundus, as it is supplied by ulnar nerve. Since the ulnar nerve is working properly, these 2 fingers find no difficulty in flexion. But when it comes to flexion of these fingers, it is to be done by the lateral half of the flexor digitorum profundus. Being a deep muscle of the anterior forearm, it is supplied by anterior interosseous nerve, branch of the median nerve. If the median nerve is compromised, these fingers find difficulty in flexion, especially the index finger is more severely affected. Even the muscle flexor pollicis longus supplied by anterior interosseous nerve is compromised and finding difficulty in flexion of the thumb. So basically these 3 fingers find difficulty in folding, giving the appearance of hand of benediction. And along with the motor problems, there will be some sensory disturbance as well, since it is injury of the median nerve above the elbow joint. And as we understand, there will be loss of sensation on the lateral 3.5 fingers, even the lateral aspect of the palm region, because that is the territory supplied by the median nerve. And of course there is the sensory loss in the lateral 3.5 fingers, including the nail beds as well. As we know, embryologically the median nerve takes care of the nail bed region also in the lateral 3.5 fingers. So in here we could see in the hand of benediction, the medial 2 fingers are able to flex as their nerve supply ulnar nerve is intact. In fact, we have got a similar question. Let us move on to that question now. And when we look at the clinical presentation of this patient is trying to make a fist. Such a statement should immediately prompt us to think in terms of the hand of benediction. And moreover, the examiner is mentioning the patient is partially flexing the index finger and the middle finger. And we already know which nerve is damaged most probably. If you go through the literature, it is mostly mentioned as the median nerve. Injury at a higher level leading to hand of benediction. The muscle supplied by median nerve in the forearm, especially the flexor digitorum profundus, gets compromised. Now, when you say your answer is choice number A, the median nerve, fine. Why you are not taking your answer as choice number D, the anterior interosseous nerve? Because this is the specific nerve to supply the lateral half of flexor digitorum profundus. So maybe that could be the answer, but still I'll prefer A is a better answer than D, since most of the authors, while describing the hand of benediction, they mention median nerve and not the anterior interosseous nerve. And despite the fact the examiner has not mentioned the sensory loss, these patients will have sensory loss in the lateral 3.5 fingers as we have seen in the diagram previously. And you must know that this anterior interosseous nerve is a motor nerve. It does not supply the skin. We have got one more question to discuss now. Let us move on to that one. This is a case of the supracondylar fracture, and the examiner is asking which is the most commonly damaged nerve. And I must tell you the answers have been changing if you follow through the literature. When we were doing MBBS and the Maheshwari orthopedics, I used to read that time the answer for this particular question was the radial nerve. It was the year 1995. Then in year 2000, when we were preparing for our PG entrance, I bought another edition of the Maheshwari orthopedics, and then the answer was changed. It had become the median nerve. And today, when you are preparing for your PG entrance exam, look at the latest edition of the Maheshwari. The answer you find is anterior interosseous nerve. So why the answers keep changing? Because as the time passes, you have a bigger subset of the patients, and as you analyze the data, the biostatistics, your knowledge improves and hence the answers change. In fact, if it is a case of supracondylar fracture, even the ulnar nerve can be damaged, though that will happen rarely. So it is basically a sequence of answer you have to remember, since all the four could be your answers of choice. So which is the best possible answer? Statistically, the best possible answer is choice number B, and if not found, then it is a better answer than choice number A. And next in sequence will be the choice number C. Lastly, you have to tell it could also be injury to ulnar nerve, though it is a rare occurrence. Now, why we have taken our answer as choice number B? Let us look at the details in the next diagram. As we continue discussing the patient of supracondylar fracture, this is the front view of the right elbow joint, showing the medial epicondyle at the lower end of the bone humerus and the lateral epicondyle. Plus, as is evident, there is a supracondylar fracture. We have to discuss the details about. We should understand that there is a nerve, ulnar nerve, which is running on the medial side, passes behind the medial epicondyle. And as it does so, it is behind the cubital fossa. It is not a content of cubital fossa. On the other hand, towards the radius side, we have the radial nerve in front of the lateral epicondyle, and it becomes a content of the cubital fossa, even the median nerve, which is running in the midline content of the cubital fossa. Let us draw this diagram. The lower end of the right humerus, describe the three nerves, and then put some details regarding the supracondylar fracture. So this is the lower end of the right humerus bone, and we are showing the front view of lateral epicondyle and also the medial epicondyle. Medial epicondyle is slightly larger, and the nerve which is passing behind the medial epicondyle is the ulnar nerve. Since the ulnar nerve is passing behind the medial epicondyle, it is not a content of the cubital fossa. Whereas if we are talking about the radial nerve, on the radial side, it will come and give some branches in front of the lateral epicondyle, and hence it definitely is a content of cubital fossa. In the cubital fossa, we have got two nerves, the radial nerve towards the radial side and then median nerve in the medial side. Now this median nerve keep running in the midline, becoming a content of cubital fossa, was giving a deep branch to supply the deep muscles of the anterior forearm. The name of the nerve is anterior interosseous nerve. And this anterior interosseous nerve is going to supply the 2.5 muscles, which you can mention the flexor pollicis longus, which is going to flex the thumb region. Then there is a pronator quadratus, a quadrangular muscle for pronation. And as we already know, lateral half of the flexor digitorum profundus. So these 2.5 muscles in the anterior forearm are supplied by the anterior interosseous nerve, and they have been compromised. And why they are compromised? Because we have got a fracture, the supracondylar fracture. So if there is a supracondylar fracture, why these 2.5 muscles have been compromised? Because this fracture will compromise the median nerve. And as the median nerve is mentioned here, it is in fact a partial injury of median nerve. Only few axons have been pulled because of this fracture. Otherwise, the main trunk of median nerve is still working. So, which axons have been pulled? The axons which enter the anterior interosseous nerve. That is what is mentioned in the literature. So, more specifically, the nerve compromises anterior interosseous nerve. Yes, that is the discussion here, leading to compromised action of the flexor pollicis longus, the pronator quadratus, and the folding of these fingers to be carried out by flexor digitorum profundus. So, whenever there is a case of supracondylar fracture, the most commonly damaged nerve is anterior interosseous nerve. And what if it is not in the options? Then you can choose the next answer, median nerve. And if that is not in the option, then you may also mention in supracondylar fracture there is a chance of radial nerve injury as well, though this will be happening less often. And what about the ulnar nerve? Is it ever getting compromised in supracondylar fracture? Yes, it can be compromised, but that will be happening very rarely. This is the last of the option you can choose. So whenever there is a question on supracondylar fracture, the most commonly damaged nerve you should answer as anterior interosseous nerve. If not found, you should take your second answer as median nerve. If missing, the third answer will be the radial nerve, and the last number in sequence should be the ulnar nerve, as it is rarely damaged in a case of supracondylar fracture. That may be happening when you were pushing a nail to treat the supracondylar fracture and iatrogenically you have damaged the ulnar nerve, and that kind of scenario is very rare. Now we talk about a case of wrist/injury. The patient had taken a blade and is putting it across the wrist level, moving from the radial to the ulnar side. Remember, the most commonly damaged nerve in wrist/injury is the median nerve, which is running almost in the midline. But if the blade goes more medial, the medial nerve running with the medial bone ulna, the ulnar nerve can also be damaged. So let us put the detail in this diagram as well. The patient has taken a blade and sliced across the wrist level. In such a scenario, the most commonly damaged nerve is the median nerve. As you see, it was found running in the midline, moving towards the hand. But then it is understood this slash injury can involve rather nerve medially, and that is the ulnar nerve, which moves along with the artery, the ulnar artery. So this is the ulnar nerve which could also get compromised in a wrist/injury. And of course, the arteries will also be getting compromised. The ulnar artery and also the radial artery. And these patients may bleed to death. We understand this radial artery is reaching the lower end of the bone radius, giving some branches, then it'll be moving towards the anatomical snub box. And we can take radial pulse at the lower end of radius, also in the anatomical snub box. So this artery gets compromised in wrist/injury. Also, as you notice, along with ulnar nerve is running the ulnar artery. So it also can get compromised. But the question is usually asking about most commonly damaged nerve in wrist/injury, and it should be answered as the median nerve. How do you identify the median nerve? From its location, it is almost in the midline and is actually found running between the two tendons. There is one tendon to its lateral side, the flexor pollicis longus tendon, and the tendon on its medial side is flexor digitorum superficialis tendon, which you can shade now. You can mention that the nerve is actually running lateral to the tendon of flexor digitorum superficialis, as evident here. And then median nerve is passing deep to flexor retinaculum, entering the palm region, giving some branches like one of this branch, which comes backward, is called as recurrent branch of median nerve. The examiner is giving some dissected specimen showing this branch, and you have to identify it. Actually, the examiners are putting markers like marker A, marker B, marker C, marker D. So you should be comfortable with this region, identifying various neurovascular bundle and the tendons, even this flexor retinaculum, which is a modification of the deep fascia attaching to the carpal bones, runs transversely, hence it is also called as transverse carpal ligament. And as we have noticed, the median nerve is passing deep to it. It gave some recurrent branch to supply muscles like abductor pollicis brevis, and then it will be supplying few more muscles of thumb region. It will also be giving branches to the skin of the 3.5 fingers on the lateral side, which will all get compromised if there was a wrist/injury involving the median nerve. And what about the ulnar nerve? Ulnar nerve and ulnar artery, they are passing superficial to the flexor retinaculum. There they'll be giving some deep and superficial branches, but both lying superficial to flexor retinaculum. Here the deep branch will be supplying the deeper muscles like the interossei muscles, and as you see, the superficial branch is going to take care of the cutaneous supply. Especially the medial 1.5 finger, the skin is supplied by branches of the ulnar nerve. Now we have to focus upon this area. There is a Guyon's canal or the ulnar tunnel lying superficial to flexor retinaculum, and we have got a separate diagram to discuss that. As we continue looking at the structures near the wrist joint, the level of flexor retinaculum shown here, it is basically a modification of the deep fascia, and as the name is suggesting, it will be retaining the tendons coming from the forearm entering the hand close to the carpal bones so that we can have good movement. So a retinaculum for the flexor tendons. The median nerve is passing deep to that, whereas ulnar nerve passes superficial to flexor retinaculum. Now, following the median nerve, we have observed that this nerve is going to pass deep to flexor retinaculum, but before it does that, it has given a branch called as the palmar cutaneous branch. And this palmar cutaneous branch, which is already given before the nerve is going deep to flexor retinaculum, is the one which is going to supply skin on the lateral aspect of the palm, the palmar cutaneous branch. And then the median nerve is passing deep to the flexor retinaculum. As it reaches here, we have seen it will give one recurrent branch. This recurrent branch is going to supply the muscles of the thumb region. So, recurrent branch to thumb muscles. And then it will also be giving the cutaneous branches for the 3.5 fingers. Then what about the 1.5 fingers and the ulnar side of the palm? That cutaneous supply is from the ulnar nerve. As you follow the ulnar nerve, it is moving along with the ulnar artery, passing superficial to flexor retinaculum. But before it reaches the level of flexor retinaculum, it gives a cutaneous branch, the palmar cutaneous branch, and this is the one which is going to supply the skin on the palm towards the ulnar side. Then the ulnar nerve is going superficial to flexor retinaculum, passing into a tunnel which is called ulnar tunnel, or the other name is Guyon's canal. And in the Guyon's canal, the ulnar nerve will be giving two branches, one superficial and one deep. The superficial branch will be going towards the skin of the 1.5 fingers, the cutaneous supply, whereas the deep branch is going to supply the hand muscles like the four palmar interossei, four dorsal interossei. But be careful, the ulnar nerve is passing superficial to flexor retinaculum. Superficially only there is a structure called as the ulnar tunnel or Guyon's canal. If it is compromised there, then there will be sensory loss on the skin of 1.5 fingers, and the hand muscles also get compromised. Now, what about that case when we were talking about wrist/injury, which is the most commonly damaged nerve? Let us look at the patient. One MCQ has come now. This patient had a wrist/injury, and the question is asking which is the most commonly damaged nerve. And as we have understood, when there is a wrist/injury, most commonly damaged nerve is the median nerve. Hence, our answer is choice number A. But then you have to be careful because the examiner can twist the stem of the question. Let us look at one more question on the same topic. What do you think is the answer now? It is also a case of the wrist/injury, but this time they have not asked most common. They're just asking which nerve is involved if there's a wrist/injury. And in such a case, you have to be careful. As we mentioned that in wrist/injury, there is always a chance of damage to ulnar nerve as well. So here, your answer should be choice number C. Now, as you talk about the previous question, what is different between this question and the previous question? See, in this question, if we change few words, like if we ask most common nerve damage, then you have to change your answer to median nerve. But since there is no description of most common, that is why in this particular question, both the nerves must be mentioned. Choice C should remain our answer here. We will be discussing the cases of carpal tunnel syndrome now, and as it is understood, there are total 8 carpal bones in 2 rows, proximally 4 bones and distally 4. total 8 bones, they are going to make a tunnel which is called as carpal tunnel, and over that there is a bridge, a transverse carpal ligament, which is also called as flexor retinaculum. So as you notice, in the proximal row we have the 4 carpal bones, namely the scaphoid, lunate, triquetrum and pisiform, and attaching to scaphoid bone laterally towards the thumb side and medially to the pisiform bone towards the little finger side is the flexor retinaculum or the transverse carpal ligament, making the roof of the carpal tunnel. As you notice, the lateral attachment is to the scaphoid bone and the medial attachment is to the pisiform bone. Then passing deep to flexor retinaculum, we have 9 flexor tendons. As you see, the section has been taken at the level of flexor retinaculum. There will be 4 tendons passing under flexor retinaculum to fold the fingers, flexor digitorum superficialis, and deep to that there are 4 tendons of FDP, flexor digitorum profundus. So here shown are the 4 tendons of FDS, and deep to that will be the 4 tendons of FDP, as we notice them here, the FDP 4 tendons. And then we have got one long tendon for flexing the thumb as well, the flexor pollicis longus. So it is shown here, the FPL, flexor pollicis longus tendon, total 9 flexor tendons under flexor retinaculum, and they are covered by the synovial sheath so as to reduce the friction while the tendons are moving. Now, what about the tendon of flexor carpus radialis? Though most of the authors will mention this tendon is passing deep to flexor retinaculum, it is to be understood that it is not exactly deep to flexor retinaculum. It is actually embedded inside the substance of flexor retinaculum. So it is neither superficial nor deep to the retinaculum, but it is embedded inside the flexor retinaculum, the tendon of flexor carpi radialis. And passing deep to the retinaculum is of course the median nerve. Then what about the structures which are passing superficial to flexor retinaculum? That is the ulnar nerve. And as we focus towards the ulnar side, the ulnar nerve is passing superficial to the flexor retinaculum in a tunnel which is called the Guyon's canal. Pisiform bone is towards the little finger side, the medial side, and the nerve is lying lateral to that in the Guyon's canal, but passing superficial to flexor retinaculum. That is why it does not get involved in carpal tunnel syndrome. So it is understood that most of the cases of carpal tunnel syndrome are idiopathic, no known etiology, but most of them are coming due to some repeat stress injury, like overuse of these 9 flexor tendons. There is a computer operator continuously working on the keyboard, overuse of the 9 flexor tendons, their inflammation, swelling, and this space is compromised, compressing the median nerve, leading to tingling sensation in the 3.5 fingers. Even there can be muscular weakness. Can you tell about any more etiology causing the carpal tunnel syndrome? A question has come, like a case of myxedema, hypothyroidism. There is myxomatous degeneration of the soft tissue and leading to compromised space in the carpal tunnel, compression of median nerve again. We are going to draw one schematic diagram here in the region of flexor retinaculum, and we have taken a section so as to draw the carpal tunnel. And we can talk about some bones here, like laterally we will have the scaphoid bone, and on the medial side we can tell the pisiform bone. So here is the pisiform bone towards the little finger medial side, and towards the thumb or lateral side we are showing the scaphoid bone. Attaching to these bones there was this flexor retinaculum, also called as the transverse carpal ligament, as it is running over the carpal bones transversely. Now this flexor retinaculum or transverse carpal ligament, there are some structures passing superficially and few structures are passing deep, like we have discussed the 4 tendons of FDS and 4 tendons of FDP covered by the synovial membrane will be passing deep to the flexor retinaculum. And along with this 4 FDS tendon and 4 FDP tendons, there is one tendon of flexor pollicis longus as well, passing under the flexor retinaculum. So total tunnel, there are 9 tendons under the flexor retinaculum, which can get inflamed due to overuse, some repeat stress injury, like we were talking about that computer operator, compressing a nerve which passes deep to flexor retinaculum, the median nerve. Now, why only the median nerve is involved and not the ulnar nerve in carpal tunnel syndrome? Because it is the median nerve which is passing in this restricted space. The ulnar nerve is actually passing superficial to the flexor retinaculum, so it is not getting involved in this syndrome. Then which other structures are passing superficial to flexor retinaculum? One tendon of the forearm, the palmaris longus. It will come from the anterior forearm and get fused with the flexor retinaculum superficially and has a degenerated tendon on the front of the hand called palmar aponeurosis. So we show it here. The palmaris longus tendon fused to the flexor retinaculum superficially. What about this tendon of flexor carpus radialis? As most of the authors mention, the tendon is passing deep to the flexor retinaculum. But in fact, exploring the further details, this is the tendon embedded within the substance of flexor retinaculum. So in fact, it is neither superficial nor deep to the flexor retinaculum. It is embedded inside the substance of the flexor retinaculum. Now, going back to that case of repeat stress injury, the computer operator having a compression of median nerve due to overuse and inflammation, swelling of the 9 flexor tendons. We are going to focus upon the clinical features now. These computer operators, as they continuously work on the keyboard, they are overusing the tendons of FDS, FDP and FPL. 4 plus 4, 8 plus 1, total 9 tendons, leading to compression of the median nerve in the carpal tunnel. I have got one diagram. You are going to tell me where will be the sensory loss if there is compression of median nerve in the carpal tunnel. So as we see, this is the diagram showing us the compression of median nerve under the flexor retinaculum. And you will mention the sensory loss will be in the anterior aspect of the 3.5 fingers, including the nail beds also, because the median nerve reaches the dorsal side of the nail beds. But my question is, will there be sensory loss in the lateral aspect of the palm region? Will there be any tingling sensation in this region or not? And if you remember, the skin on the lateral aspect of the palm will be spared in a case of carpal tunnel syndrome, because we know the palmar cutaneous branch from the median nerve was already given before the nerve enters the carpal tunnel under the flexor retinaculum. So compression level is distal. The branch is already given proximal. It will be working. No sensory disturbance in the lateral aspect of the skin of the palm. The sensory disturbance, tingling sensation and all that is restricted only to 3.5 fingers, not the palm. Now you will be doing certain tests in a case of carpal tunnel syndrome, like Fallen test, Tinel test. We'll be looking at some photographs now. For the Fallen test, you have to show the patient to do a particular movement, and the patient will be then following your movement. So basically you are looking for confirmation of the median nerve, whether it is compressed or not. If it is already compressed and you are further compressing it by this maneuver, the tingling sensation will increase and you say Fallen test has become positive, taking you close to the diagnosis of median nerve compression or carpal tunnel syndrome. So as you see, the median nerve, which already is compressed under the flexor retinaculum, you are further compressing it, which obviously will then increase the tingling sensation in the fingers. If the patient is suggesting that, you will say the Fallen test has become positive. As the median nerve is regenerating, to check that regeneration, you can do the Tinel test, where you have to take a knee hammer and tap on the median nerve. If that tapping is going to increase the tingling sensation, the patient tells that I have more of tingling now, it is a good sign. And why it is a good sign? Because that tells us that the nerve is regenerating. So hitting the regenerating nerve, if it brings more of the symptoms, it is a good sign. Tinel test has become positive. It is showing the signs of improvement in the nerve. Now this is about the sensory disturbance. What about the motor disturbances? If the compression is severe and prolonged, there can be Cases of ape thumb deformity. Let us look at the next diagram now. This is the computer operator we were talking about, and as you notice, the patient is having ape thumb deformity. Not only there is thenar atrophy, the thumb muscles are losing the mass bilaterally, but there is ADD, adduction deformity as well. And why the patient is having adduction deformity? See, the thumb muscles, thenar muscles, they are undergoing atrophy because they depend upon the supply by the median nerve. And median nerve has been compromised under the flexor retinaculum. If it is unable to supply the thenar muscles, they will obviously be paralyzed and they'll be disused atrophy. But why the thumb is in ADD, adduction deformity? Due to the unopposed action of ADD, adductor pollicis. And why the ADD, adductor pollicis, has become more powerful? Since it is supplied by the deep branch of ulnar nerve. Ulnar nerve is still working. Median nerve is compromised. And it is the median nerve which is supplying muscle like abductor pollicis brevis not working. Now if the abductor of the thumb is not working, the adductor becomes unopposed. That is why there is ADD, adduction deformity. This is what we call as ape thumb deformity, but we have more details to discuss. Our test will become positive. The pen test has become positive. Let us look at a photograph where we are conducting the pen test. Now, this is our patient and we are asking the patient to perform a specific movement. This is one normal individual. You are doing the pen test. You have to take the pen and ask the patient to touch the pen with his thumb. And this movement requires anterior abduction of the thumb. The muscle needed is abductor pollicis brevis, which is purely supplied by median nerve. If there is compression of median nerve, abductor pollicis brevis not working, patient cannot touch the pen. And you will say the pen test has become positive due to median nerve compression leading to paralysis of abductor pollicis brevis. So basically, in this movement called as anterior abduction of thumb, we require the participation of abductor pollicis brevis muscle, which is purely supplied by the median nerve. And if median nerve is compromised, abductor pollicis brevis is paralyzed, no anti-abduction, pen test becomes positive, which tells us about the case. Could be carpal tunnel syndrome. In fact, the thumb remains in ADD, adductor posture. Now here I must tell you, thumb has two types of abductions. One is the anterior abduction and then there is lateral abduction. Maybe the anterior abduction of the thumb has been lost, but the lateral abduction of thumb is still possible. Let me demonstrate the movement once again. This is the normal position in anatomical position. And if you take the thumb anterior abduction, palmar abduction, that is done by abductor pollicis brevis, a muscle of the thumb region. So this is your movement here. But then there is another movement. You are taking the thumb away from the palm. And that is what we are calling as the radial deviation or the lateral deviation. See, this is done by a posterior forearm muscle. If you remember, we have discussed that earlier as well. The abductor pollicis longus, taking the thumb away from the hand. Lateral abduction, radial abduction, to be done by the branch of radial nerve, posterior interosseous nerve. So posterior interosseous nerve supplying abductor pollicis longus still functional in a case of carpal tunnel syndrome. And not only the patient can take the thumb lateral, but he can bring it back also, which is called ADD, adduction. But how the patient will bring the thumb back, ADD adduction? Because ulnar nerve is still working, ADD, adductor pollicis is still working. So thumb abduction is possible and thumb adduction is also possible in this axis. Let us talk about the thumb apposition, where you are counting the fingers, touching the tip of thumb with the tip of other fingers. This thumb apposition requires 3 movements in a sequence, and we are going to discuss about that in the next diagram. We need to understand that the movement of thumb apposition is a complex movement and it will be requiring the participation of at least 3 muscles. And which 3 muscles? They are in a sequence. Number 1, abductor pollicis brevis, which is for anterior abduction of the thumb, And number 2, it is the opponent's pollicis, which is for the medial rotation of the thumb. And the third one is, in a sequence, the flexor pollicis brevis, which is causing flexion of the thumb. And it is a sequential movement. Let me demonstrate the movement for you. You will see, number 1, from the anatomical position, you are moving the thumb away in anterior direction, anterior abduction. It is done by abductor pollicis brevis supplied by the median nerve. And after that, the second movement is you have to rotate the thumb medially towards the little finger. Medial rotation of thumb done by opponent's pollicis muscle. And then comes the third movement, the flexion, folding of the thumb. And that is done by flexor pollicis brevis. So number 1, anterior abduction. Number 2, medial rotation. And number 3, flexion. That is how you do thumb apposition. Now, if it is a case of carpal tunnel syndrome leading to compression of the median nerve, leading to paralysis of the abductor pollicis brevis, since the abductor pollicis brevis is purely supplied by median nerve, there will be no possibility of anterior abduction of the thumb. Actually, the pen test will become positive. The thumb cannot do anterior abduction. It will actually remain in ADD, adductor deformity. And this will lead to loss of thumb apposition. And when there is loss of thumb apposition, that is what we call as ape thumb deformity. Because it is the human thumb which is opposable. The apes do not have opposable thumb as efficient as humans. So the thumb appears like the thumb of ape with loss of thumb apposition. Now be careful here. This ape thumb deformity has occurred just due to paralysis of one muscle, which is abductor pollicis brevis. It may be possible that the opponent's pollicis and flexor pollicis brevis muscles are still working. But how can they be still working when median nerve has been compromised? Because if you remember, we have mentioned they are hybrid muscles. They have additional supply from ulnar nerve as well. So the ulnar nerve as well as the median nerve is supplying the hybrid muscles, opponent's pollicis and flexor pollicis brevis, and they may be still working, but they will be of no use for doing the thumb apposition because the stage 1 anterior abduction itself has been compromised. If stage 1 is not happening, stage 2 and 3, they are useless. If the thumb remains in ADD adducted posture, how can you rotate it medial or fold it? So despite the fact that these muscles may be still functional, thumb apposition is not possible. Or in effect, you can say, why do you have loss of thumb apposition? Just because of one muscle paralyzed, that is the abductor pollicis brevis. This is all important because when we are dealing with MCQs, this kind of information is required. It is essential. Now tell me, this patient is unable to do anterior abduction of thumb. Can he do lateral abduction of thumb? Yes, lateral abduction of thumb is possible because of abductor pollicis longus supplied by posterior interosseous nerve branch of the radial nerve. Now this patient takes the thumb away. Can he bring it back? ADD adduction? Yes, ADD adduction is possible because of the transverse head of adductor pollicis that pulls it back, supplied by deep branch of ulnar nerve. This patient has injury of median nerve. The ulnar nerve is still working. So ADD adduction is possible. Can this patient do thumb flexion? Yes, thumb flexion is possible because a muscle, flexor pollicis longus, is still working. But how come it is still working? Because if there is median nerve compression in carpal tunnel syndrome under the flexor retinaculum, only the distal muscles get compromised, not the proximal muscle. Median nerve has already supplied the muscles in the anterior forearm, hence flexor pollicis longus still working. It is to be supplied by a deep branch of median nerve, anterior interosseous nerve, supplying flexor pollicis longus, still functional. Can you do thumb extension then? Yes, it is possible. Thumb extension is still possible because it is to be done by extensor pollicis muscles. And these extensor pollicis muscles, they can pull the thumb back using the nerve, posterior interosseous nerve, branch of the radial nerve. So let us write it down in a table before we reach one MCQ. We'll be requiring all this information to justify our answer there. Continuing with the patient, we had repeat stress injury, a computer operator with carpal tunnel syndrome, injury of median nerve, loss of thumb apposition. Let us write it down here. The carpal tunnel syndrome leading to injury of the median nerve and paralysis of the abductor pollicis brevis leading to loss of thumb apposition, and that is what we are calling as the ape thumb deformity. And then we are mentioning this patient can still do few other movements of thumb like abduction, adduction, flexion, extension, and how, that is what we'll write in the table. How this patient is doing the other movements like the thumb, abduction and adduction, the flexion and extension. We will also be talking about the muscles involved and their nerve supply. Now maybe this patient cannot do the thumb anterior abduction because the abductor pollicis brevis is not working, anterior abduction not working, but still the patient can do lateral abduction. And for that, the patient is using posterior forearm muscle supplied by the posterior interosseous nerve branch of the radial nerve. So lateral abduction of thumb is still possible. And what about the ADD adduction? It is to be done by the adductor pollicis muscle to be supplied by ulnar nerve, which is still functional. And then flexion, it is done by the flexor pollicis longus, the anterior forearm muscle. A deep branch of median nerve, anterior interosseous nerve, is taking care of this muscle. So median nerve giving anterior interosseous nerve to the flexor pollicis longus can fold the thumb. If you want to unfold it, extend it, then the posterior forearm muscle, extensor pollicis longus, is going to help us, and supplied by the posterior forearm nerve, posterior interosseous nerve, branch of the radial nerve. So as we can see, the patient is able to do extension, flexion of the thumb, even abduction, adduction of the thumb. The only movement which was compromised is thumb abduction on the anterior aspect, leading to a thumb deformity in carpal tunnel syndrome. And we need all this to tackle the MCQ, which is coming up. And as we see, this is a case of carpal tunnel syndrome, which basically is compromising the median nerve, leading to a thumb deformity. So there'll be inability to do which movement? We already know it is the loss of thumb apposition. Now, when you say your answer is choice number D, can you tell me which muscle has been paralyzed so that there is no possibility of thumb apposition? Only one. The name of that muscle is abductor pollicis brevis, which is purely supplied by the median nerve. If median nerve is not working, this muscle is not working. Now, maybe your answer is choice number D. What about the opponent's pollicis? Is it working? Yes, opponent's pollicis may still be working because of its additional supply from the ulnar nerve. But opponent's is useless at this moment because the first movement of thumb apposition, anterior abduction of thumb, itself is not happening. Then obviously stage number 2 or 3 are useless. And what about this abduction of thumb? Which abduction are you talking about? The lateral abduction of thumb. And who is doing this lateral abduction of thumb? It is to be done by a posterior forearm muscle, abductor pollicis longus, taking the thumb away. Lateral abduction, radial abduction, supplied by posterior interosseous nerve, branch of the radial nerve. It is still possible. Okay, what about the ADD adductor? The adductor pollicis is supplied by the ulnar nerve. It can always bring the thumb back. This is a case of median nerve injury. Ulnar nerve is still working. So ADD adduction is still possible. And what about this thumb flexion? That thumb flexion is possible. The distal phalanx can still flex because of flexor pollicis longus supplied by anterior interosseous nerve branch of the median nerve. So in this particular question, the only possible answer is choice number D, and we'll keep it so. How do you deal with such a case? We have to give them splints, especially night splints, which will keep the palm straight, and maybe that will help in reducing the sensory symptoms and improvement of motor function as well. But if conservative treatment is not working, the night splints are not helping, you have to go for radical treatment. A zigzag incision is done, the flexor retinaculum is incised, and decompression of median nerve. That will release the median nerve compression and the symptomology will improve. Let us look at one diagram for the same. So here is the zigzag incision we are talking about, and we are decompressing the median nerve, which is shown here. This is the flexor retinaculum, which we are incising with the help of a scalpel and releasing the tension on the nerve. So this transverse carpal ligament or flexor retinaculum has been incised, and the tingling sensation or other symptomology will improve in the patient.